Let's discuss about retinitis pigmentosa. Retinitis pigmentosa. Before going into the topic, we need to remember about night blindness. Since the essay questions are mostly asked with respect to night blindness and retinitis pigmentosa, so let us go into that. Cause of night blindness is include vitamin A deficiency, retinitis pigmentosa, congenital night blindness, and your pathologic myopia. So, what is retinitis pigmentosa? Retinitis pigmentosa is the primarily pigmented retinal dystrophy. Primarily pigmented retinal dystrophy. More rods or more than cones is affected, and inheritance is mostly sporadic and inherited. Sporadic is 50% and inherited is via the genes, X-linked recessive genes and your ADRP and ARRP. Your prevalence is 1/5000 population in the world, and the childhood it appears and progresses slowly and cause blindness in the mid-age. More commonly male are affected than the female, and more commonly bilateral eyes are affected than the unilateral. You should remember this. Male are more commonly affected, 3:2 ratio. Bilateral eyes are affected, prevalence is 1/5000. So it is a progressive primarily pigmented retinal dystrophy. So rods are more affected than cones. Pathogenesis. So what happens here? Death of rod cells will happen. So that causes via molecular mechanism. Via molecular mechanism, there will be death of rod cells. Progressively, it leads to death of cone cells. So it is basically two types of retinal pigmentosa: type 1 and type 2. Type 1 is your early preferential loss of rod sensitivity. Early sign is diminution of night vision and laterally progress to the regression of specific vision loss. Type 2 is your progressive and combined loss of rods and cone sensitivity and later onset of the diminution of vision. So the clinical features include your visual symptoms like nyctalopia, dark adaptation, tubular vision, and later progresses to the loss of central vision too. So first you should remember one thing: rods, most commonly rods will be affected, then the cones will be affected, unless it is type 2 retinitis pigmentosa, where it is combined loss of both rods and cones. And you should remember tubular vision, and then it will come loss of central vision. And your fundus examination will show perivascular bony spicules in the mid-peripheral retina. This is very important feature, very important feature that you need to remember. So this is your perivascular bony spicules in the mid-peripheral retina. Mid-peripheral retina, there will be perivascular bony spicules, and alternate retinal arteriole is present, waxy pallor of optical disc is present, and choroidal sclerosis is present, cystoid macular edema is present, and colloid bodies are present. Your visual field will show annular scotoma that leads to tubular vision, and that finally leads to your blindness. ERG and EOG, electroretinography and electrooculography will be first subnormal and then extinguished. Subnormal with the absence of the light field, light peak is also present. Your primary associations will be in ocular associations that will cause primary open angle glaucoma, myopia, and keratoconus. Systemic diseases include your Lawrence-Moon-Badel syndrome, your Refsum disease, and your Cochlear syndrome. Your Refsum disease is important. Retinitis pigmentosa, peripheral neuropathy, and cerebral ataxia are association. Lawrence-Moon-Badel syndrome, it has association with retinitis pigmentosa, obesity, polydactyly, and mental retardation. And Usher's syndrome, there it is having 3 features. So these are some associations that you should remember. Just remember the syndromes names, that is enough. And treatment is to stop progression of the disease. We should give vasodilator, placental extracts, and your transplantation of rectus muscle into the suprachoroidal space. Your light exclusion therapy, ultrasonic therapy, and acupuncture technique, vitamin A are given. Refractive error correction can be done, and astazolamide of 500 mg is given for the treatment of cystoid macular edema. Bone marrow derived mononuclear resection can be done. Embryonic stem cell induced pluripotent stem cells and retinal progressive cells are injected in the subretinal space. As a replacement therapy, it is done. Thank you.